Students, this is Dr. Lisa Pullen. I will be talking about trauma and stress-related disorders and dissociative disorders. I have worked with the VA population at an outpatient community-based clinic. I have treated trauma and stress-related disorders, and I currently treat some of those in the practice that I'm currently in. We'll also cover dissociative disorders. The disorders that we'll talk about today, the new one is reactive attachment disorder. Then we have PTSD and complex PTSD, acute stress disorder, adjustment disorder, dissociative amnesia, depersonalization, and derealization. And I forgot disinhibited social engagement disorder. That is a new one as well, along with reactive attachment disorder. So clinical rating scales for anxiety disorders. This is actually what we've already talked about in the anxiety disorder presentation. The new disorders to review: reactive attachment disorder, the diagnostic criteria. The code is F94.1. It's a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers manifested by 1. Rarely or minimally seeks comfort when distressed, and 2. Rarely or minimally responds to comfort when distressed. B. Persistent social and emotional disturbance. 2 of the following must be present: 1. Minimal social and emotional responsiveness to others. 2. Limited positive affect. 3. Episodes of unexplained irritability, sadness, or fearfulness evident during non-threatening interactions with adult caregivers. Reactive attachment disorder, again, this criteria is continuing. C. Experience pattern of extremes of insufficient care, at least one, by adult caregivers. 1. You have social neglect or deprivation, persistent lack of basic emotional needs for comfort, stimulation, and affection. You have repeated changes in primary caregivers that limit opportunities to form stable attachments. 3. Rearing in unusual settings that severely limit opportunities for selective attachments. D. Criterion C is presumed responsible for the disturbed behavior of criterion A. And this is the D, disturbance in behavior of criterion A. Students begins following a lack of adequate care as described in criterion C. And then E through G does not meet criterion for autism spectrum disorder. Disturbances were evident before age 5, and there is a developmental level of at least 9 months old. This inhibited social engagement disorder, the diagnostic criteria, the code is F94.2. You see a pattern of behavior in which a child actively approaches and interacts with unfamiliar adults. 2 of the following must be present: 1. Reduced, absent, approaching, interacting with unfamiliar adults. 2. Overly familiar verbal or physical behavior that is not consistent with culturally or age-appropriate social boundaries. 3. Diminished or absent checking with adult caregiver after venturing away, even in unfamiliar settings. 4. Willingness to go with an unfamiliar adult with minimal or no hesitation. B. Criterion A is not limited to impulsivity, such as in ADHD, but includes socially disinhibited behavior. And then C, experience a pattern of extremes of insufficient care, at least one, by adult caregivers. 1. Social neglect or deprivation, persistent lack of basic emotional needs for comfort, stimulation, and affection. 2. Repeated changes in primary caregivers that limit opportunities to form stable attachments. 3. Rearing in unusual settings that severely limit opportunities for selective attachments. D. Criterion C, presumed responsible for disturbed behavior of criterion A. E, developmental level for at least 9 months old. There's no criteria limiting development and evidence of symptoms being before age 5, as in reactive attachment disorder students. In the clinical presentation, RAD versus DSED comparison. RAD, the temperament is inhibited, internalized. They are emotionally restricted, blunted except for extreme reactivity to non-threatening interactions with adults and caregivers, little exhibition of positive emotions, unexplained irritability, sadness, or fearfulness during non-threatening interactions, impaired social interactions, constantly pushing boundaries, resistance and reactivity to forming emotional attachments to others, the experience of extreme neglect prior to age 2, DSED, the temperament, they're easy, they're externalized, emotionally generally happy, bubbly, never meet a stranger, extremely poor boundaries with strangers, no checking with caregiver for safety in new environments, readily follows any older person, are you my mom now, high risk of abduction and sexual abuse, and general lack of fear. Some of the shared traits students, symptoms present prior to age 5 with RAD, developmental age of at least 9 months old, history of extremely insufficient or inconsistent care, social neglect or deprivation, persistent lack of basic emotional need for comfort, stimulation and affection, rearing in unusual setting that severely limits opportunities for attachment, repeated changes in primary caregivers that limit opportunities to form selective stable attachments, orphanage, repeated foster home or caregiver changes, repeated institutionalized. Yes. Prevalence, of course, of RAD and DSED. DSED prevalence is unknown, approximately 20% in high-risk populations, severely neglected, foster care, institutions, no evidence of association with neglect after 2 years of age, unclear how long symptoms persist. RAD, prevalence unknown, less than 10% in high-risk populations. Must rule out autism spectrum disorders, unclear how long symptoms persist. Students, again, the high-risk populations are the severely neglected, repeated or multiple foster care placements, raised in institutions such as orphanages. Now let's talk about post-traumatic stress disorder, PTSD or F43.10. It was added, PTSD, it was added to the DSM-3 students in about 1980, but it was not applied to children until the DSM-3-TR in 1987. When the DSM-5 and ICD-11 codes came out, PTSD has been conceptualized differently. CPTSD, which is complex post-traumatic stress disorder symptoms, have been included in PTSD in the DSM and separated as a distinctive diagnosis in ICD. This creates significant issues in understanding how these symptoms can be differentiated in different populations. But these are, the behaviors. I talk about behaviors in mental health instead of symptoms that we talk about in medical health. The patient experience of a qualifying traumatic event. Again, the patient could have observed it. They may not have directly experienced it. Intrusive symptoms, internal avoidance, negative alterations in cognitions and mood, and alterations in arousal and reactivity. Complex PTSD, it's due to severe and repeated trauma, chronic pattern of extreme trauma like slavery, genocide, chronic childhood abuse, war. It meets the criteria for PTSD. It exhibits symptoms, the patient exhibits symptoms consistent with disturbance of self-organization. They have issues with affective regulation, emotional dysregulation, negative self-concept, pervasive difference with interpersonal relationships. And there are concerned students about missing a correct diagnosis depending on which diagnostic model is used. But this is the PTSD and the complex PTSD clinical presentation. You see a decline in occupational academic functioning, newer increased substance abuse, mood lability, instability. I'm fine on second and then I'm ready to fight the next. Self-depreciating thoughts, statements, guilt, shame, suicidal ideation, impaired sleep or sleep-wake disruptions. Children under 6, increased crying or clinging to caregiver. Behavior similar to ODD or oppositional defiant disorder, nightmares, decreased function tolerance, insecure attachment. So post-traumatic stress disorder, you can have it with dissociative symptoms, which are depersonalization and derealization. Depersonalization, students, is a feeling where the patient feels detached from themselves and is if one were an outside observer of one's mental process or body, as in a dream, unreality of self or body or of time moving slowly. Then derealization is the unreality of surroundings. World is experienced as unreal, dreamlike, distant, or distorted. Excuse me. Then you can have it with delayed expression. That means, students, the full diagnostic criteria is not met until at least 6 months after the event. Some symptoms may begin immediately. The comorbidity, 80% more likely to have another mental health disorder. Depression is common. Of course, anxiety, substance abuse. Comorbid substance use, as I mentioned, and our conduct disorder more common in males. Mild traumatic brain injury with veterans is 48%. In children, I've already mentioned oppositional defiant disorder and our separation anxiety disorder are common. We have to look at prevalence and course. Of course, we have to look, students, at the other events associated, especially, like after the Holocaust and later with natural disasters and other sources of physical assaults brought more, recognition. Early psychoanalysts, they said it was the relationship between neurosis, which neurosis, Freud came up with the term neurosis because he worked with a lot of women over a lot of years who he said were prone to a lot of anxiety. So neurosis was changed in the DSM, I think it was to anxiety disorders and trauma. World War I and II brought the attention of PTSD to the forefront with the battle fatigue, the shell shock, and the soldier's heart. Untreated lifetime, 30% fully recover and 40% maintain mild symptoms. 10% will remain unchanged or worsen. 50% will recover without treatment within 1 year. Most prevalent in young adults, but can happen in any age. The lifetime prevalence general population is 6.8%. Women is 9.7%. Men is 3.6%. Veterans, look at the significant difference. 30.9, adolescent girls, 8, children, 0.1. Unrecognized symptoms, high resiliency, and short-lived symptoms. Most symptoms are subclinical. Then we have acute stress disorder, which if you would look at your DSM-5, you can see all the criteria and information about ASD. Traumatic events are the same as those who develop PTSD, but only duration of symptoms is less. It can't be diagnosed, students, until after 3 days, but symptoms typically begin within minutes or hours after the event. With children and youth, you see emotional instability and reactivity more common. Parents may report significant changes in range of emotional expression, bright, positive, affect to negative. They have generalized fears that may develop and significant increased risk of suicide attempts and completion. The diagnostic features, You must be able to identify the source of emotional behavior changes to give students this diagnosis. So presence of emotional or behavioral symptoms in response to an identifiable stressor is essential for making this diagnosis. Qualifying stressors affect only the patient or may involve the family or even an entire neighborhood or community. It's associated with developmental periods or events. Death of a loved one, if the intensity, quality, or persistence of grief reactions exceeds expectations, must consider culture, religious, and age-related norms. Then the acute stress disorder of prevalence and course. I do encourage you students to read the diagnostic and associated features in the DSM-5, page 281 through 284. These pages, students, explain in more detail actual events and symptoms associated with both PTSD and ASD. Single events such as like a romantic breakup, being unexpectedly fired from the job, multiple stressors in one or more areas of life like work and relationships, continuous stressors like increasing severity or disability of chronic illness, long-term pain, living in an unsafe or crime-ridden neighborhood. An acute onset is usually immediate within 3 days and lasts no more than a few months. Persistent, the stressor or its consequences persist or multiply. Adjustment disorder can continue and become a persistent form. Again, prevalence varies according to the nature of the traumatic event. 20 to 50% off after interpersonal events, outpatient 5 to 20%, and inpatient up to 50%, 13 to 20% from car accidents, 14% mild TBI, 19% assaults, 10% severe burns, and 6 to 12% industrial accidents. So dissociative amnesia and fugue are the dissociative disorders. We have to rule out neurological medical conditions like partial complex seizures, transient global amnesia, and sequela students of a closed head injury related to causing traumatic brain injury. It's an inability to recall important autobiographical information, usually of a traumatic or stressful nature that is inconsistent with ordinary forgetting. And this can occur when people have been through severe trauma. Specifier with dissociative fugue, apparently purposeful travel or bewildered wandering that is associated with amnesia for identity or other important autobiographical information. Yes, the trauma is so severe. And there was an article many years ago about a person who was from California that ended up in New York City. Did not know anything as far as her autobiographical information. It took many months to find out who she was, where she was from, because she had dissociative fugue from being sexually abused by multiple partners that her mother had had over the years since she was 2 years of age. And she was 19 years of age when this happened and was on the news. Okay, dissociative amnesia, prevalence and course. I want to say that localized is the most common form of dissociative amnesia. It's the inability to recall events during a specific time period, months of years during childhood abuse or intense combat. And then we have selective amnesia, which is the ability to recall some but not all events during a specified time period. Then we have generalized. You will see these all over on the right-hand side of this PowerPoint. They are rare. The patient has complete loss of memory from one's life history, may involve loss of personal identity, knowledge gained of the world, or well-learned skills, and it typically is an acute onset with noted experience of disorientation and purposeless wandering. And then we have the systematized, which is a loss of memory for a specific category of information. And then you see the continuous, forgetting each new event as it occurs. Again, little is known due to lack of evident symptoms, even to the person, typically preceded by overwhelming or intolerant events. I often report multiple episodes without symptoms being evident between episodes. Some people report both localized and selective amnesia. Length of time affected can range from minutes to decades, can occur at any age, but often decreases with age. Reports from several sources are needed to diagnose in children. Onset, localized, may be delayed for hours, days, or longer, and generalized sudden acute onset. Students with depersonalization and derealization disorder, there can be symptoms of other disorders. Do not give this diagnosis if there are symptoms that are better explained by another disorder, students such as PTSD, GAD, mania, depression, etc. I have already went over the definitions of depersonalization or derealization, but you see these again. It certainly doesn't hurt to review this, information to help you understand the difference between depersonalization and derealization, and some examples are given there. Depersonalization, derealization disorder, the prevalence and course. The prevalence, at least 50% of the general population has experienced one transient episode. Diagnosis, estimated lifetime prevalence 2% with no difference for gender. Course, 16-year-old is mean age of onset, but can start anytime during early or middle childhood. Less than 20% onset after age 20, 5% after age 25. Usual if onset after age 30. Onset of symptoms can be gradual or extremely sudden and last hours, days, weeks, months, or years. Generally persistent course, 1 to 3 split in presentation, being discrete episodes. Continues from start or initially episodic, then progressing to be continuous. Intensity can vary or be consistent. External factors impact this. Exacerbations can be triggered by stress, worsening mood, anxiety, novel or overstimulating setting, or physically, such as lightning or lack of sleep. Risk and prognostic factors. The highest risk students is with prior diagnosis of panic, depression, PTS, and OCD. The higher the severity of the event, the more likely to develop PTSD. That makes sense. PTSD, CPTSD, risk and prognosis, the risk factors, prior traumatic exposure or mental health diagnosis. Externalizing behaviors, lower socioeconomic status, lower level of education intelligence, history of childhood adversity, culturally based coping strategies, minority, marginalized social status, younger age and female gender, prognosis indicators, severity, duration, and proximity of exposure, most important risk factors, social support, experience of dissociative symptoms. Then we have acute stress disorder, risk and prognostic factors. Temperamental, prior mental health disorder, high levels of negative affectivity, greater perception of traumatic event, castratic appraisals with exaggerated appraisals of future harm, guilt, or hopelessness are more indicative of acute stress disorder, avoidant coping style. And then the environmental, have they had a history of prior trauma? Do they have social support? That can make a significant difference. Genetic, physiological, female gender, elevated reactivity, acoustic startle response, prior history of trauma, culture-related diagnostic issues. Culturally shaped symptom profiles may include variations of dissociative symptoms such as possession or trance-like behaviors. Panic attacks are more often seen in some cultures. Then the etiology sources for ASD. 20 to 50% after interpersonal events, assault, rape, witnessing mass shooting, etc. 13 to 21% from car accidents. 14% from mild TBI, 19% from assaults, 10% from severe burns, and 6 to 12% from industrial accidents. Dissociative amnesia, risk and prognostic factors. Environmental, single or repeated traumatic experiences, more likely with more adverse childhood experiences, especially physical, sexual abuse, interpersonal violence, increased severity, frequency, and violence of trauma, genetic, physiological, no genetic studies, but some studies report possible genetic and environmental factors, prognostic modifiers, removal of the traumatic circumstances underlying the dissociative amnesia may bring about more rapid return of memory. Onset of PTSD symptoms may decrease amnesia, which is a form possibly of flashbacks. Please, students, review the differential diagnoses for all disorders covered in this lecture in your DSM. Depersonalization, derealization disorder, risk and prognostic factors. Temperamental, harm, avoidant temperament and immature defenses, idealization, devaluation, projecting and acting out in denial of reality and poor adaptation. Cognitive disconnection, schemata, defensiveness and emotional inhibition, themes of abuse, neglect and deprivation, overconnecting, schemata, impaired autonomy with themes of dependency, vulnerability, and incompetence. Environmental, clear association with childhood interpersonal traumas. Traumas are not as prevalent, extreme as in other dissociative disorders. Emotional abuse and neglect most strongly and consistently associated. Common proximal precipitants are extreme stress, interpersonal, financial, occupational, depression, anxiety, panic attacks, and illicit drug use. THC, hallucinogens, ketamine, MDMDs, salvia. THC is associated with simultaneous new onset panic attacks and depersonalization and derealization.